one. I was looking here to see if Dr. Munson has made it.
I have.
Okay, well, thank you. I'm slow looking through the names of people here, so good. I think that's all of us then, isn't it? Oh, there you are. Hello, Dr. Munson. So it looks like we have our quorum, so that's good. So I guess we'll just start off then. Oh, Dr. Sawyer. That's right. I knew I was forgetting somebody, but we still have a quorum, so I guess we can go ahead and begin if you all are ready. Everything good for you all? Fair enough.
Let's do it.
Sounds good. Okay. Well, as always, we'll call the meeting to order here with a quorum, and first order of business is the approval of the minutes from the last meeting. Everybody had a chance to review those, and everything okay there? If so, we'll take a motion.
I make a motion to approve the minutes.
Second.
Fair enough. There you go. Well, with a motion and a second, any other discussion on them? Everything look good to you all? Fair enough. All those in favor of approving the minutes from the last meeting, say aye.
Aye.
Good. And any opposed? Perfect. Okay, well, I may need a little help, Dr. Munson, because I missed the last TAC meeting, and I think you were so gracious to run that one. So I may have to refer to you on some old business stuff, but we'll see how it goes here. March Vision, the first, going down the list as we always do. The first order of business for March Vision was the discussion that was had on the OD and OMD billing discussion. And I think, Steve, that might have been something that you had spearheaded the discussion of to start with. Have we gotten any other information, or does March have anything they would like to say on that topic?
Good afternoon. This is Ann Ritchie with March Vision Care. We did review this citation, had a couple of internal meetings, and it is our understanding that we are currently in compliance. So if there are, some additional questions or, further discussion that's needed, we're certainly happy to take that offline and, have some, individual smaller meetings, but like I said, understand that we are, currently in compliance there.
So then all optometrists and ophthalmologists credential with the same plan or payer, and are treated the same as in terms of reimbursement and things like that.
Like I said, that's our understanding, and I think if we want further discussions or get into real specifics, it would make sense just to have an offline meeting. But yes, that is our understanding.
Okay, well, and that's great. I think if we did have a meeting about that, I think we should probably have the department involved in that meeting too, as far as that would go, if something comes about. But as far as I know on my end, I don't know of an instance, unless Steve or Gary, Carolyn, or James, unless you all have anything where you've seen any discrepancy there.
Matt, so Matt, go ahead, Steve.
Well, I missed part of the discussion. I had to get back in on my iPad. I lost all the audio on my PC, so I don't know what was said other than March. at least thinks they're in compliance.
They said after some internal discussions that they feel that they are in compliance with the statute.
Okay.
Yeah, and this is Ann at March, and I had mentioned that, you know, if we need to have, you know, additional discussion or go into some real specifics, we're happy to do that, but, you know, should do that offline. And I think it was Dr. Burchett mentioned maybe, you know, invite the department to that. But again, seems like, you know, anything more detailed, we'd be happy to take offline.
I'm no attorney. I'm not sure offline's legal either. These are open meetings.
Well, excuse me, folks. This is John Ryan. I'm the CEO of March Vision, United Healthcare Vision. And I've been kept up to date by the team that's been on this call. So I appreciate not only your work, but their work. So Ann Ritchie and Scott Edmonds and others who've participated report up to me. So the reason I wanted to sit in on this is exactly this issue. So first of all, when we said we've had internal meetings, we've consulted with our legal counsel. That's why we feel we're in compliance. The second issue is similar to what you were saying, I think, Dr. Compton, is that I'm not really sure how comfortable any of us should be discussing this issue on a large call like this too. We have multiple payers. We have multiple managed vision plans. So we feel we are in compliance. This issue, I think, has been discussed multiple times. If we really need to get into the very specifics of why March is felt not to be in compliance, then that's a conversation we should have directly with you, not with other people on the phone. How that has to occur legally, or who needs to be included, we can discuss that. But no disrespect at all to my other, you know, kind of fellow vision plans and payers that are on the call. But that's something we should talk about directly. I'm just as concerned on the flip side about having open dialogues like this when it gets into processes and how we interpret things, especially if reimbursement starts to kind of factor into this in some way, shape, or form. I
agree. I don't want any collusion issue. I mean, there's all kinds of legal issues out there.
Yep.
I do. If nothing's changed, I do think we need to discuss it further because
okay.
I know you've got all the attorneys, this, that, and the other. I just know what the intent of the law was when it was passed, and I don't think it meets that legislative intent.
Okay.
The way you're currently on it.
Completely fair to, you know, and trust me, sounds like you and others have had that, you know, the intent versus how it's interpreted versus actually promulgated. So again, the reason I'm on the call is I'm happy to have those conversations. If you guys want to structure that, we will, myself included, as the executive owner, I will absolutely be part of those. Our goal is to get to an amenable place where the provider community feels comfortable, as well as clearly it's meeting, you know, what everyone feels is viable. So let's put that offline. You guys can work with Ann Ritchie to kind of set that up, and we'll make sure we come to the table, you know, to have that dialogue. But I would much prefer that we get it into where it should be, including some of the other issues that I think are on this agenda, but I'll leave it to other people. I think we all have to be very careful about what we're talking about with competitors, us being one in the same room at the same time.
I think we have to be careful both directions.
Mr. Ryan, this is Lee Geis. I'm with the Department for Medicaid Services.
Slowly.
And I'm sorry I didn't catch it at first. If you should be referred to as Dr. Ryan, I apologize.
No, I'm not a clinician, ma'am.
Okay. The purpose of the TAC is to talk about issues that anything the TAC wants to talk about. Other certainly have discussed what their overarching policies are in this arena, and at a very high level. No one else that I've heard of has any issue with talking about their policies at a very high level. This is a government, you know, so with government, we have to be fairly transparent about things. If you feel that you can't discuss this without encroaching upon some proprietary information, that's certainly understandable. And yes, we in the government do understand that there are some proprietary areas between the MCOs and the providers. So, but I just wanted to make sure that if Steve Compton has something in particular that he wants to offer up, he can certainly offer that up during this meeting and ask questions during the meeting. And then if you don't feel comfortable, then a private meeting can be certainly had, but likely not. Let me see. What was I going to say there? And the department would be happy to participate. I just wanted to clarify that it's perfectly reasonable to talk about things in this meeting.
Oh, no. So Lee, thank you for that clarification. And if I gave the impression that we didn't think any conversation should be had, that was not my intent. So thank you. Understood and appreciate, and I understand that this body, collective body, has come together and had those kind of productive conversations. So I appreciate that. Where I do get concerned is we kind of keep going over the same issue. And if we need to go deeper into what our contracting is, how we contract, why we think it's meeting this, then that absolutely, to me, gets into kind of our processes. And we would welcome the offline conversation with the right people, including the department. We have no qualms about that. I think because this issue's been discussed a couple of times and doesn't seem to be meeting, kind of resolution in the eyes of KOA or whomever, then we're probably at that point, is another kind of position I think I'm taking.
Thank you.
Thank you. Thank you for the clarification. So yeah, again, completely open to the questions. We can take those. And then if we feel for some reason that it does require, us to have the more of a one-to-one or, the right body conversation, we will set that up with urgency. Thank you.
Dr. Burchett, I'll leave that up to you if you want to pursue this further. And Dr. Munson.
Well, Steve, if you feel like the question hasn't been answered or rectified to satisfaction, and I think we probably should.
And I don't. And it's not that I'm just concerned that one little thing slides by now, then something a little bigger slides. I'm worried about the precedent it might be setting. So, yes, I would like to pursue it further.
Okay. Well, again, Ann Ritchie, if I can ask you to be on point for us, and if any of the specifics can be shared that haven't already been discussed previously, but I understand the intent, I understand the concern about precedent. I'd also like to make sure we're dealing with specific things. It is absolutely in our interest to make you guys feel that kind of precedent will lead into an unintended consequence, and but the letter and the intent are aligned.
Yeah, this is Ann, and I'll certainly be happy to help coordinate that. I'll put my email address in the chat, best way to reach out to me, and then I can make certain that we've got the right team members here from the vision team.
Okay. And we'll move on, and we'll look forward to having that side meeting there. The next thing was the medical refraction from March. Was there any update or any ideas to review having more than one refraction available per year to the covered entities?
Yeah, this is Scott Edmonds, and I'm the Chief Eye Care Officer on behalf of this point. Also practicing optometrist and do a lot of low vision and work in concert with my medical colleagues at Wills Eye Hospital. So know exactly what you mean by a medical refraction, we do them all the time. However, there's really no code for a medical refraction, really hard to differentiate that from a refraction that's done to change the glasses. So the way we always do it, and the way the policy is that if you see a patient, for let's say you see a patient with post-op transplant, or someone that's has a retinal detachment, vision's down, and you're wondering if perhaps swelling or other issues are going to cause that's the reason, and whether you want to know what their best vision can be. So you refract that patient to decide, through the edema or whatever, to get what their best vision is, with no intent on prescribing that. You just want to know what the best acuity is. So that is just part of your medical care. So if I was going to see a patient, so all the 99 codes are time-based now. So if I saw a patient that would take me, let's say, 25 minutes to do the other part of the exam, that would be a 99213. But then if I did a refractive work to kind of see what their best vision was, and it took me another 10 minutes, now I'm at 35 minutes. So now it's a level 4 medical office visit. So you do get paid. It isn't called out as a refraction per se, because again, it's not meet the criteria for what we normally use that code for. And there's not a separate CPT code for a medical refraction. And the process is a little different, again, because you're not going to prescribe glasses off that. So we believe it's covered as part of medical care. It takes time. That time is all billable time. It just changed your 99 code to reflect the added time for that particular analysis.
Well, I think we probably all will disagree that there is a CPT code for it. It's 92015, done in conjunction with care of whatever medical condition, because it is a separately listed testing code under the CPT guidelines. But to that effect, I don't know, does anybody else want to weigh in?
I mean, some of the other provider groups or other MCOs have talked about it being diagnosis based. And so that's a very easy way to separate out when you bill a 92015. If you have a diagnosis that is anything that was just detailed in his examples, then that would be a way that it was paid out. If it's a refractive diagnosis, then it's not paid out.
Yeah, I think we've contemplated that, but it gets to be a problem of how do you limit it? It obviously would then be set up on specific diagnosis where we would pay it. But again, since it's easily added to your time for medical care, since the 99 codes went time-based as opposed to the traditional way to measure it, it just seems like it isn't an issue. And so, our policy is to just pay it as medical care and not report it out separately as a refraction.
Anybody else have any question or comment to that?
Man, I was kind of under the impression that some of this was also, is there a limit to the number of refractions, for your diabetics or whatever, those medical diagnoses? I mean, if you do it this way, there's not, how many office visits you want.
Yeah, obviously, if it's just time-based medical care, it's unlimited. You can do them as much as you want. I think refraction is defined in the Medicaid standings that that we comply with, and it is a time benefit to change the glasses. But when you do it as part of your medical analysis, and so sometimes those of us that do it, it's just a retinoscopy just to see if indeed the pathologies change the refractive error, as opposed to sitting there and refining it. So it could be something quick, but it's adding time to your medical care. So that's why our policy is to make it part of medical care, not call it out as a separate issue, because the code that you're calling out is a time benefit according to the Medicaid regs.
I'll have to review the regs to confirm that, because I haven't looked at if refraction is a time-based situation in the regs or not. I don't recall off the top of my head, but Thanks for the update in your policies.
Thank you.
Any other comment there from the group before we move on? And the next one, we can move on to Avisus. And it looks like we have an update on Refraction being paid with 92 codes, 92 codes. Did we still have some issue with that from last meeting that we just needed an update on?
Dr. Burchett, are you asking that the other committee members confirm that they're receiving payment appropriately? Are you asking Avisus to confirm that we have it configured correctly?
From the last meeting, I'm just making sure that everybody's getting that, because I think there was initially some problem. I think I had some problem too.
Yes.
Yeah, we paused that because you weren't on the meeting. So that's from 2 meetings ago.
Okay.
Because that was an issue that you were seeing. So.
Right. That's fine. I was just going through my notes, making sure here.
Okay.
Thank you.
And, yep. For you, Dr. Burchett, just confirmation that that is resolved.
I haven't heard in my office anymore that it's been an issue. So.
Okay. Okay.
Yep.
Our provider relations representative, Miranda's on the line. She did confirm in working with your office that we have taken care of the currently we're paying them correctly. The ones that we had payment issues in the past, we have resolved. We have 4 that are still in the re-adjudication process, but we do expect that payment to be released within the next 2 payment cycles.
Sounds good. Appreciate that. And the next, I guess, looks like it's for the department. I think we looked to add a code for payment. And we emailed it to Justin Derringer. Has that been added to the fee schedule? Do we know? Oh, there he is, Justin.
Good afternoon. My name is Justin Derringer. I'm the Assistant Director, Department for Medicaid Policy and Operations Division. I did receive that email, and after some research looking into Medicare payments and several other surrounding states, we decided to add that to the vision fee schedule. So that's in the process right now and
Okay.
On its way to being added.
Any timetable we think, or?
No, it just kind of depends on, there's a process that's involved in that with systems, getting the systems in place. But that'll be actually put on the fee schedule, this week sometime. But as far as systems and payments and all that stuff, I'm not exactly 100% sure, but it is in the process, in the works. So it shouldn't be too awful long.
Okay. Appreciate that. Well, I guess if it pleases the committee, we'll move on to new business. The first order there was WellCare. Looks like just an explanation of your termination and re-credentialing process, if you wouldn't mind.
Yeah, this is Stuart Owen with WellCare, and actually for all the vision providers, Avisus handles that. So I think Nicole was going to address the instructions.
Sure. Thank you. So for the termination and re-credentialing process, we are processing the providers re-credentialing in accordance with our re-credentialing criteria. So unfortunately, if the re-credentialing is not completed timely, after the multiple notices are given, as well as feedback from the provider relations team, a termination notice is sent. According to the DMS criteria, we also have to notify members of all of the members that a provider treated within the last 6 months. So member notices go out, a notice goes out to the provider. If the provider's Kentucky Medicaid ID number remains active, so there isn't a lapse during the time that we've terminated the provider, then we can reissue the provider's effective date so that there isn't a lapse in coverage once we receive all of that information. So we do have kind of some backup processes in place to try to have the least disruption to the provider's offices. In regards to the letters that are sent out to the members, for the letters that are sent to the members, once we have the provider reinstated, we will send letters to those same members to notify them that the provider is now active and they can continue any course of treatment or future treatment with that office. Does that help address the question?
This is Dr. Compton. I put this issue on here because I was terminated.
Yeah, we
Don't-
did see that after the
don't-
fact.
I don't know why. We got no notice. The letter that my patients got is from WellCare, not Avisus. I mean, it plainly says our records show that you have seen or will see Dr. Stephen Compton. You need to pick a new provider.
Yes, yes. And the
So-
letter. Mhm.
When should we, how would we have known to re-credential with WellCare? We've done all the Medicaid stuff.
Right, right. So the letter, has the WellCare logo on it. And Avisa sends it on behalf of WellCare because we are their benefit administrator. But all of the MCOs, send a letter out. Some of them Avisa sends directly. Others, the other MCOs will send directly to you and to your patients.
So why did it go out? We checked and double checked. We had done all the credentialing. We got no notice that we're about to be terminated, nothing.
So we can look
Phone
into
call or something would have alleviated a lot of heartache.
Sure. So we'll look into your specific case, Dr. Compton, to see what exactly happened. I can speak to our protocol. So when a provider is due for re-credentialing, we do send out an initial notice prior to the re-cred date. And Miranda or Leanne, please correct me. I think it is at the 6-month period. Is that correct, Leanne, that we send the re-cred notice out? I'm sorry. Are you there, Leanne or Miranda? Okay, so I apologize. Oh, go ahead.
Sorry, this is Miranda. It is supposed to be sent out at 6 months.
Perfect. Okay, so we send out the initial notice at 6 months. We send another notice out at 4 months. Those notices are sent via mail. And then at 3 months, we then make a phone call to the office. If we don't hear back from you at that 3-month point, then we do phone calls with the office. We also hold monthly webinars, and in those monthly webinars, we have just a webinar that is only for re-cred, and only for credentialing and re-cred that an office staff can participate in. So again, Dr. Compton, we can look into your specific issue and follow up with you to identify why it occurred.
Let's do, please, because we got none of that. No phone calls, no letters. Now we moved at the first of the year, but that's 6 months. Would have been before that.
Right.
And the phone number didn't change.
Right. Yes. Okay. Well, we will follow up with you and discuss it.
All right. Thank you, Nicole.
You're welcome.
Then the next item was a question on iQuest for criteria for laser procedures and Durista, treatment with Durista. Steve, was this yours again?
Well, yeah, our office.
I thought so.
I like to stir the pot, We have these meetings for a reason, right? Yeah, we had a little, I can't think of the doctor's name, John Davis, maybe.
Yeah, Dr.
That's
Davis.
right. When my partner, who's also my son, called to get a prior approval for a YAG cap, I think, Cindy, is that right? And, you know, we got the 2-line drop in acuity, and we've done a brightness acuity test and all those sorts of things. And he basically said, yeah, that's the criteria, but he didn't believe it or some sort of thing. And then we got into, or they did, that YAG SLTs can't be a first line treatment. And the literature says it can. So I guess we just need to know the criteria, and do we follow the science, or does the guy doing the PA just get to use his own opinion and approve
Well,
it? He approved it, but it was
yeah.
like,
Dr. Compton, this is John
and
Davis.
you're on here. It's
I'm-
my son you talked to.
Yeah, no, I remember chatting with your son, and
Yeah.
we went at length about some of the overriding protocols and some of the reasons for some of these criteria and whatever. But I'm happy to kind of expound a little bit here in this setting.
Okay.
So at the end of the day, right, we do have very established, criteria, clinical criteria for the 3 laser procedures, the primary 3 laser procedure do, plus the Durista, which is a brand new one, more or less. I guess it's about a year old, that policy. But speaking to the lasers, which are the more common services that are provided by providers in Kentucky. By the way, these criteria apply to every type of practitioner, OMDs, DOs, ODs, whatever, right? Same stuff. And just to go specifically to the SLT, the standard of care is not for SLT to be the primary, a first line treatment. That's not standard of care. It might be in the county you're in Kentucky, and there could be this debate about that out there in the world. But I will tell you that I have a lot of glaucoma specialists. I'm talking about OMD fellowship trained glaucomas that do not do SLT as a first line, except in cases, and this is something I would have discussed with your son, I'm sure, when we chatted about it. There are definitely cases. And oh, by the way, just to preface everything else, my preference is I feel like SLT should be primary mode of treatment for many cases of glaucoma. That's just my personal preference. So I don't go by my personal preference. I go by the standard of care and the common community standard of care, which is that SLT is not yet there. We do not think. And the criteria, the policy you see has that. Now, are there extenuating circumstances in specific cases that it is a good idea? Absolutely. And guess what? That's what the PA is about, right? You have a unique situation. Patient either is constantly forgetting their drops, or they have issues with mobility. They can't even put the drops in their eyes, or they live in a setting like a long-term care facility, or they have whatever situation they have that is very specific to them. And it's like, let's just do the SLT and prevent this patient from having to deal with these drops all the time. Absolutely. And that's going to pass the criteria, and it certainly would pass a peer-to-peer review, which happens if you were to be denied at the initial presentation. So, and some of the stuff that your son really understood well, because his charts were amazingly documented. I mean, I was like one of the best I've ever seen as far as charts. But the initial denial, there was no chart sent in the first place. So that's really why I called, to be honest with you, because I thought he didn't or the office didn't understand it. So I called, because I know you guys are a pretty high volume practice for Anthem patients who we cover. So anyway, I don't want to kind of get too deep into this thing. I mean, I know you guys have other items on the agenda, but those criteria are available. And I think I felt like I sent him.
You may have. Yeah, I gotta go pay him on back now, right, for keeping good.
Yeah. Okay, but either way, it's pretty much all of our clinical criteria and guidelines are all based around local care determination or national care determination, or if the state Medicaid program happens to have criteria for some of this stuff, which they don't have. Kentucky Medicaid doesn't have any criteria for any of this stuff. Then that would be the prevailing sort of guidelines, or the essence of the guideline.
Okay.
But
I
we do
just needed some clarification.
Okay,
yeah, and that helps.
Sure.
So no, and I agree. The standard of care is still medically.
But don't be afraid to. And I'm talking about to any TAC plus whatever, any OD that's doing these procedures. Don't be afraid to advocate for your patients when you feel like it is the best thing for them. Period, as opposed to a convenience thing. I'm sorry they don't want to go to the drugstore and get their drops updated. I mean, but that's not Medicaid's problem in a way, right? Fair enough.
Fair enough.
Okay. Good deal.
All right.
Thanks, Doctor.
Thank you.
Appreciate it.
John, since I've got you on here, I'm going to ask another question. It kind of along the same lines, you said all these policies you said were available for the different laser procedures, things like that. Would that be true too for like visual field or OCT usage, things like that?
Yeah, we have
policies in place.
We have guidelines for all those as well, for sure.
Okay.
You know, you gotta,
where can we find those?
you just have to ask for them.
Well,
now, if you
we
want them in
have-
advance, we can post. I mean, you're talking about, 70 guidelines, and I don't know how many pages that is on the portal. Is that what
Right.
you're asking?
That would probably be, I think, the easiest for all providers to access, because everybody gets on the portal to do their interchange with you all.
Okay.
But I was just asking, kind of piggybacking on Steve, because we've had a denial of the visual field, and in talking with Mary from iQuest, there was a thing on the denial that says the guideline is available if we ask for it. And my billing person asked her for the guideline, and she says that there wasn't one.
Oh,
So that's why I'm asking, where are they, and
yeah.
do we have them?
Oh, yes, and yes. So Mary, who does claims, she might have overstepped there, because I don't know that she has the list of the whole list. Matter of fact, that's what I think we'll post, is the table of contents of all of the criteria and the policies. And I will definitely make sure our claims people are aware of that as well.
Okay.
Good.
So,
Thanks. Yeah, I'm glad. I'm glad. Appreciate that heads up, though. Even that's important.
Right. Well, and that's why I asked, because I assume everybody has them, because everybody previous TAC meetings have said that they have them, and I was just a little bewildered, I guess, when my billing person came to me and said, "Well, we asked for the guidelines so you could look at it, but they said they didn't have any." So,
okay. Yeah, and a good rule of thumb, with iQuest is we do appreciate the dialogue with the providers who get an adverse determination on something, so that we understand, so we can clarify. And you talk to another optometrist, frankly, if you
Sure.
were to inquire about that. And it doesn't happen that often, I don't think, as far as the number of denials total, but when it happens, you like to know where you stand. Like, just like Dr. Compton's son was like, wait a minute, I don't get it now. I need to know more to really know how to practice within this, with you guys, and understand where you're coming from. And it ends up being a pretty good dialogue as a general rule.
Sure. Okay. Appreciate that.
It almost seems like if providers are expected to follow the guidelines, there should be an easy, accessible place to look at those guidelines to avoid denial.
Yeah, that's true.
Amen.
That's true.
And
that's where I'm thinking about, the breadth of posting all these to the portal. So we're going to look into that, I think, straight away, and see if it makes sense to try to do that. Or do I want to do like in some of our office reference manuals, not Kentucky, we do abbreviated guidelines within the office reference manual. That's sort of like the primary starting point kind of thing, the simple stuff. And maybe that makes sense for this type of situation, because it's especially for the more common ones. We're going to look into it. I'll talk to my peer review committee. Actually, we get together and we talk about these kind of things, and see where it makes sense. And these are, as a matter of fact, I have somebody on my peer review committee that's a Kentucky based optometrist.
Appreciate that.
Sound good?
If you
Okay.
could keep us abreast of the decision on where you're going to put it.
Oh, definitely. Yeah, it'll be before. We'll decide this before the next TAC for sure. So you'll be the committee will get caught up to speed, and we'll let you know what's going on. So that at least then you'll be able to test it to bring it back to the next TAC and see if it's sufficient.
Okay, that'd be great. Appreciate you.
All right.
Moving on, I think the next is for maybe the department. It looks like. I know my practice has been a casualty of this issue, and I don't know if any of the rest of y'all have had this problem or not, but we've been knocked off. I think it's a visas, trying to remember, because they said that the information that they received from the department didn't have us as being re-credentialed through Medicaid when we've been re-credentialed in Medicaid for some time. And they said it was through the portal that they were having some trouble getting the files updated.
This is Jennifer Dudinsky. I'm with the Division of Program Integrity. So provider enrollment falls under my area. Generally speaking, when a license is uploaded into the portal, depending on how busy we are at that time, it most likely takes 2 to 3 weeks for that to be processed. So if you're doing a maintenance or revalidating, it's about a 2 to 3 week time frame. Just so you're aware of that, because I know that was one of the questions you had. As far as the information being fed to the MCOs, the file is actually sent on a nightly basis. So if something is uploaded into the system during that day, then nightly that should feed over. That's not to say there couldn't be mistakes or errors, but that is our process. It is a nightly feed. And as far as knowing about the license being uploaded properly, there is a notification on your dashboard that should tell you if there was a problem. And there's generally comments in there that kind of addresses specifically what that problem is with the upload. So there is a notification for that. When in question though, you can also go in yourself, should be able to, and go in and try to pull it up and see what it looks like in the portal if you think that there might be a problem with it. So this is the first I've heard that there have been issues. Nobody's reached out to me. So what I'm going to do is I'm going to put my email address and the branch manager's email address in the chat for you all. And if something specific comes up and you all want to reach out to us, we're happy to kind of look into it and see what the problem is and try to help correct it.
And I'm not sure, I don't think any of the other MCOs or vision providers had issue with our office's information other than Visas. So I'm not sure what transpired there.
Sure. So with Avisus, we do process DMS's daily provider file. And if a provider's Medicaid ID number is termed on the DMS daily provider file, we have to reflect that within our system, because under the regs, we cannot release Medicaid funding to a provider that is not active with DMS. And that's part of the reasons for some of the terms that we've been encountering. So as soon as that information is updated on the DMS provider file, and as long as there isn't a lapse in coverage, then we will reinstate the provider back to the date that DMS reinstates them on the DMS provider file. Unfortunately, though, if DMS terms the provider, let's say on 5/1, you upload your license on 5/2, and if it takes 2 to 3 weeks for DMS to update their system, unfortunately, you will still show as inactive with Avisus for that time frame, which again is going to generate the member notification. It's going to stop paying claims for data services incurred after that termination date. But as soon as that information is updated with DMS, we do upload that information into the system. And I apologize, I should clarify. When the information is reflected on the DMS provider file, that's when we can upload the provider.
Okay, thank you, Nicole. And I'm not sure, I get all your all's who does what for Visas mixed up sometimes. I think Miranda is looking into it for us.
Okay.
That is correct.
Yes.
Because it's one day it'll be one provider and you'll pay half the claims and not some of the others. And then the next day it'll be a different one and the other one will start paying again. I'm not sure what's happening, but she's working with one of my office staff members to try to figure it out.
Okay. Okay. We appreciate that. Well, we'll continue to work with Miranda, and please let us know if there's anything else we can do.
Okay, thank you much.
Mhm.
I guess the next item is a discussion on the glasses provided by the MCOs. It looks like our first question would be frequency and limitations on adult glasses. Has any of that changed? Or is everything still, I guess, the same as what it has been?
So Avisa's met with each of our MCO clients, and they all agreed to put a side-by-side outline of their adult eye care glasses. I have that document if you'd like me to share it with you. I've also sent the document to Sarah with the KOA. So Sarah will share the physical copy of the document for you. We're hoping your team can use it as a cheat sheet to help you easily identify the benefits and the levels of coverage that each of the plans offer. So I do have it for Aetna, Humana, and WellCare, if you like me to show it, or I can just send it over.
Well, is that on your portal as well?
I just created it, so we can upload it, but Sarah does have a PDF copy of it, so she can email that out to everyone. Also, our Miranda and Leanne are on the call, so they can email it to your office too.
Sure.
Nicole, this is Dr. Munson. I really appreciate you putting the effort into making that PDF, because that does make it so much easier for us as providers to kind of figure out what those 3 carriers that you cover, what they cover for our patients. So I appreciate that access to that data.
You're welcome. And I should not take full credit. Danny helped me put it together too, so I can't take all the credit.
Well, thank Danny then too. We appreciate it.
No, Nicole should take most of the credit. I only piggybacked off of what she started, so we're good. Teamwork.
Teamwork.
And this is Jean O'Brien with Anthem. Nothing's changed with our value-added benefit for the adult glasses. Okay.
And this is
So
Tanya.
That's
once every
12.
2 years or once a
Ours
year?
is every year.
Okay.
Dr. Munson, it's every
Thank
12
you.
months. Yeah. And then we also cover the $50 for the contact lenses.
Okay.
And I
And that's it.
apologize. I'm sorry, Dr. Burchett, I just wanted to say I neglected to add that each plan's plan sheet, which identifies the benefits, is also listed on our portal. So in addition to the cheat sheet, you do have the detail listing that is currently listed on the portal. I apologize.
Okay. Thank you.
And none of the benefits for Aetna Better Health, Humana, or WellCare has changed. So they are the current benefits that you've seen for the last year or 2.
Okay.
And the same goes for March Vision Care for United and Molina. Nothing has changed. And all of our benefit outlines, summaries are on our website at marchvisioncare.com.
So can you clarify what your frequency is for March and for United Healthcare adult beneficiaries?
Yes, I can. So it's 1 unit every 2 calendar years for ages 21 and older.
Okay. Thank you.
You're welcome.
And this is also Ann at March Vision, and we do have some documentation that Tanya pulled together for us on that. So I can make sure that we get that to Sarah at the KOA, just if that's helpful.
Yes, please.
Yes.
We will be happy to do that.
Thanks, Ann.
You're very welcome.
Okay, moving on down. This is for everybody as well. I know everybody has the benefit for the children's glasses, but do they have the possibility of upgrades to those glasses? Say if they wanted to get a transition lens or tint to their lenses or something like that.
This is Nicole with Avisus. Yes, however, it does have to be medically necessary. Children,
even if they want to pay for the upgrade.
if they want to pay for the upgrade, they will pay for it out of pocket.
Sure.
We do encourage you to please make sure that you do have a letter or a document that confirms the family is accepting financial responsibility for that. Please keep it in the medical record. So if the patient does come back and issue a complaint, you have the documentation we need to support your office. But if the patient wants it and it's not covered, yes. If the patient needs it and it's medically necessary, please submit a authorization request under EPSDT criteria. For children, anything that's medically necessary is covered under EPSDT.
This is John Davis, iQuest. I'd like to mirror exactly what Nicole so beautifully stated, because that's exactly the Anthem program as well. So just like that. So thanks, Nicole.
Yep. And I'll echo that too from March Vision Care. And it is outlined on the portal in the provider reference guide on the non-covered services and the waiver that's required.
So for everyone, all three of you, if a patient that is a minor wants a different frame, so not one either in the frame kit,
Right.
depending on which provider. So how, that's the only thing I understand, like if they want anti-reflective coating or transitions, that's easy to separate out and say this is their portion, and then the carrier will cover the basic lenses. But for a different frame, is it basically all or nothing, or is there a part, and I'll let Nicole go first, is there a part that Avisus would pay and then the patient's family is able to pay the difference?
It is an all or nothing, and that is
Okay.
defined on the plan sheet. It's also on the grid that we'll email out over, but it does state if they don't use something from the frame kit, then they do have to pay for that. And Danny, I'm going to ask for your help. Can you confirm for WellCare, they have a dollar limit?
So are we talking about kids or adults now?
Kids
I
right
thought we
now.
were talking about kids. Okay. So in the kids section, so I'm looking at a couple of the plan sheets. They do have a member buy-up. It's explained on the second page of the plan sheets. For the lab providers and in-house fabrication providers, if they choose to do a buy-up, then they will have to pay out of pocket for the entire pair. So the state does allow
the entire
for
frame or the entire pair, because the pair would include the lens.
the frame. I'm sorry. So yeah,
Okay,
for the entire service that they don't use as a Medicaid covered benefit, they'll have to pay out of pocket on that. So
Okay.
it does allow for buy-up, but they will have to pay out of pocket, and that goes for the kids and the adults.
Okay.
WellCare is a little bit different because now they have an allowance. So anything that's over the allowance would be member responsibility.
Okay, that
For adults.
doesn't make sense to me. So if you have a frame
For the adults, yes, you're
Okay.
right, Dr. Bridget.
So kids, it's all or nothing. They either get a frame that's within WellCare's covered amount, or they pay everything out of pocket for a frame.
For a frame, yes.
Okay, perfect.
Yes.
And then what about iQuest?
Same thing.
Okay,
It's all or
and-
none on the frame upgrade.
Perfect. And then March?
This is Ann at March. It's the same.
Okay, perfect. Thank you.
You're welcome.
I'm sorry, I was on mute, talking away.
This is James. Can I ask a question?
Go ahead, James.
We were just talking here. We understand that if you do an upgrade like this, then the provider loses the dispensing fee. Am I right on that? Especially with the visas, we're thinking that's the way it is, but I may be wrong.
Yes, I want to say that you are correct in that. I'd have to pull up all specific 3 plan sheets and take a peek, but yes, that will be noted in the paragraphs on the second page under the member buy-up section.
So even if they only upgrade the frame, they get the lenses on Medicaid, there is no dispensing fee to the provider, right?
Correct.
Thanks.
Are we not dispensing that? Like, just out of curiosity, like, is a ferry taking it to their house? Because we're still providing that service, period. So is that anything that can be reviewed?
We can take that back.
Dr.
mean,
Munson, we can definitely take that back.
Because
and-
from
Mhm.
our perspective in our office, our staff is still making sure that the lenses were made to specification. They are adjusting the frame. There's staff time. So all of the service is still being provided,
Right.
but we're not being compensated for that solely because the patient decided to upgrade a frame. And, you know, that doesn't make sense because we're still providing all of that dispensing service regardless of which frame. And to be quite honest, that is something that, you know, I mean, it could be easier, or it could be harder depending on the frame that they pick out.
Right. Okay. Please let us take that back in and we'll follow up with you. And then if we can put it on the agenda for the next TAC to discuss the resolution. Out of
Perfect. Thank you.
curiosity, you're welcome. Out of curiosity, can you share with us how DMS handles that situation?
Me personally, I don't have the answer to that, but I'm sure DMS on the call does. I cannot recall a time when DMS ever changed. There is a dispensing fee that is paid and then a replacement pair dispensing fee. And I do know that those historically were different, but they were always paid depending on whether it was the initial pair or a replacement pair.
Okay,
Yep.
but so it didn't matter where the patient received, if the patient upgraded on the frame or not, it still was released?
To the best of my
Yes.
knowledge, but okay. Thank you,
Yes.
ma'am.
Great, thank you, that's helpful. Okay, we'll take that back.
I mean, you know, Dr. Munson, I guess the other option is just to hand them the frame and be, here you go. Good luck.
Right. Don't adjust it, you know, which is poor customer service. And I'm sure
Yeah,
not how
yeah.
the department wants us to take care of a subset of population.
So that was for Avisus. And everybody else answered too, if my notes are correct, right? Okay. Okay, good deal. Next, March Vision. If I read my notes right, just an explanation of requirement for adult to receive glasses for United.
So this is Tanya, and the benefit is outlined on the portal for adults and all of the requirements that go with it. It's one unit every 2 calendar years for adults. And there are a bunch of bullets that I could walk through right now, or you could look at the document that Sarah will be sending over with all of the criteria that needs to be met for adults. And that also can be found at marchvisioncare.com under the benefits summary for adults.
James, would you like for that explanation, or do you want to look at what they've sent over first and maybe come back to it next time if you have questions?
Say that again, Matt, I'm sorry.
Do you want to, like she had just mentioned, do you want to look at what she has sent over to Sarah and see if that makes sense to you on this topic, or would you like for her to talk more about it?
No, that'll be fine. We were told if we have an authorization number to go into that, then that usually will clear that. It will go through at that point. Yeah. So, but I'll talk with Sarah about that too and see what she has. That'll be fine.
And to your point, yes, if you have a confirmation number for the services that you're adding for a covered member, it will go through. And then all of the criteria is listed for you to meet, to kind of look at, to make sure that that member has met that criteria, or patient, I should say.
Okay.
Thanks.
You're welcome.
Next is iQuest on discussing the upgrades for adult glasses.
Right, this is John Davis going to reply to that if that's okay.
Yep.
So the way the adult eyewear benefit works is the patients get a standard pair of glasses, standard frame, standard flat top, or single vision CR39 lens, right? So nothing unique there. They get that every year, every 12 months. So that's just that's the built-in benefit. Now, but if they want high index, or if they want photochromatic or progressive or anything else that's not standard, including, by the way, I was reminded recently that poly was a little unclear in our documentation. Polycarbonate in that, you know, just to lighten the lenses or to make them a little thinner, whatever. All of those are available for optional purchase by the member. So they would pay a fee. The glasses would be made by the lab, our lab, and then they would there'd be a chargeback fee back to the practitioner, and the practitioner would collect the let's call it the recommended co-insurance or co-payment, whatever term we want to use there, for that service. Did I goof that up a little bit? You understand? So there's the patient can optionally buy any of those things. And the case that came up about the poly was the fact that the patient had, you know, was amblyopic and this was an adult, but it didn't matter. I mean, the member could still purchase the poly. It wasn't going to be covered by the program. Just to make that clear. Yes.
Even in cases if they're monocular, things like that.
Yeah. I mean, again, don't forget where that stems from, right? The state of Kentucky doesn't recognize any patient, any adults get glasses at all from the state, right? Regardless of their situation, unless I'm wrong about that.
No, I just wanted to make sure on because there's been sometimes it's come up, you know, not just amblyopic, but they only have one functioning eye. So
right. No, that's where it is today, though. But right, it's not relevant really.
One question on that, Dr. Davis, because you and I talked at length.
Mm-hmm.
And you sent me the chart. So do we need to have an account with the optical, or is it classic?
No.
Okay. We just order it and then they will subtract it from
right. Sort of like the VSP, you know, the old school chargeback that maybe they still do. I think they still do it. It's the same story that's been around for 30 years. Similar, right? Just like that.
That's a bad word, you know.
Yeah, I know.
Yeah. And so also on this list that you sent me, it has member charge if not covered as medically necessary. So you and I talked once before. So do we have to charge what is on this list, or do we charge our usual and customary?
You can charge your usual and customary. That's basically recommended. I'm sorry that was not clear, because when I looked at it, actually, as I was sending it to, I said, you know, it's not really clear here that this is a recommended sort of out of pocket for the patient.
Okay.
So you can charge whatever you feel is appropriate and more or less.
Right. Okay.
Yeah. Great question. Mm-hmm.
Are we good with that?
We're good.
Okay. And next, let's could we have maybe an answer to the next 3 questions on the list from all of the vision care providers there, if they have some of those numbers?
So this is Nicole with Avisis. For the percentages, I think that's what you're referring to. We don't have that information. We give the providers the options of what services they would like to utilize and what services they provide in their office. And then, but we don't track which providers do what. We do have some that share that information with us. So unfortunately, we can't give you this information for our network.
Christina, you want to handle that one for iQuest?
Sure. So this is Christina for iQuest, and for our end, we have we did some analysis, and we're showing that 16% of the optometrists use their own labs versus the kits. We got about 9% that are not offering glasses. And then the rest, 75% of the network is using the glasses kit.
This is Tanya from March. All of our network providers use their own labs. And then for bullet 2, 15% of our optometrists do not offer glasses.
Sorry, I missed the answer to the first one.
All of our providers in our network
okay.
use their own. Yep.
Thank you.
You're welcome.
Any questions about that from anyone? The next little bullet point, I know I've been thinking about for a little while and talking to different providers that I run into at meetings, things like that. Something for the TAC to consider as maybe a recommendation to send up to the MAC is that all of the MCOs offer some kind of a standard frame kit that everyone would have the same benefit, same frames, be able to access things like that. So I just wanted to throw that out there for consideration, possible discussion. See how you all might feel about it.
Are you asking that they each individually have a frame kit, or that there's a universal frame kit that all of the MCOs use?
There you go, universal.
Okay, just checking.
And I'm sorry, Dr. Burchett, was that question for DMS or were you asking for each MCO's input?
I was asking the TAC what their thoughts on making a recommendation to the MAC according to something like that might be. If there's any desire to have any kind of universal scenario there.
I feel like it makes it a very level playing field for our little kids across the board. And also from a provider standpoint, it definitely streamlines it, as opposed to, oh, wait, this person has Anthem, you got to use their frame kit. No, wait, you got to use Avisis's frame kit. And then also just the amount of room that takes up in a dispensary to try to keep them all separate. So if that is possible with the different MCOs to have some type of consensus, that would be amazing.
This is Steve Compton. Maybe we give them a chance to talk amongst themselves and see if that's a possibility before we take it as a recommendation to the MAC.
Sure.
Is that plausible?
No, that's fine.
Yeah.
I just, like I said, I'm just throwing that out there for thoughts because, like Dr. Munson had stated, I've talked to a lot of docs across Kentucky that have the same kind of issues of trying to keep each frame kit separate and know who's got what and things like that. So, you know, I was just churning things around in my own head. I thought if there was a universal, everybody used the same kit per se, that could solve a whole lot of problems.
Yeah, it's an administrative burden and it's a burden on your square footage too. So yeah, it'd be great.
This is John Davis. I mean, I don't think it's a problem. I would do a little mini survey here amongst the three of us here, March and Avisis and iQuest. I think it's probably worth discussion. I don't know. You know, one of the things we're learning now is that there are issues with supply chain and getting frames and from different manufacturers, and there are problems with that. So I'm not sure if, you know, but we'd have to but we could get past that by some discussion, I think. Nicole, do you feel like Avisis would be amenable to at least getting a dialogue started, or what?
We can definitely have a dialogue. I think our hurdle is going to be getting our different vendors to utilize the same or to offer the same frames. Because who we utilize and who iQuest utilizes are different vendors or different eyewear suppliers, and those eyewear suppliers may not offer the same frames. So it's not completely our issue. It's if the eyewear suppliers would be willing to offer the same frames.
Mhm. I mean, I see that as one of the barriers for sure. So,
Yeah.
all right, so maybe we'll, and if March is interested in joining that little discussion, maybe we can set up a meeting in the next month.
Yeah,
Sounds
this
good.
is.
Walk. Go ahead, Ann.
Oh, I'm sorry. I was just going to say, yeah, this is Ann Ritchie at March, and more than happy to participate in that discussion. You've got my email in the chat, so please, please reach out.
Okay. Yeah, if you want, I'll spearhead that. I'll get you guys by email. I'll contact you and see if we can put something together. Sound good?
Okay.
That sounds great.
Okay.
Dr. Davis, do you still have my contact information?
Oh yeah.
Okay. Dr. Davis and I are old buddies, so.
Okay, good. So anyway, it's worthwhile to have the discussion because you can see there is some value in it to some of the stakeholders for sure.
This is James. I would comment from our perspective as a small office, small town, our patients are going to run into each other. Everybody's going to have the same pair of glasses on. With the number of Medicaid that we have, I mean, that's primarily what we have. And it would have to be a pretty large selection, I would think, in order for that not to happen. If there's, just a half a dozen girls' frames, half a dozen boys' frames, they're all going to see each other coming and going all day at school and things like that.
Dr. Sawyer, that came to my mind immediately because I've been in that situation in another life where that's exactly what's a big problem.
Yeah,
But,
and
go ahead, Nicole. I'm sorry.
I'm sorry, Dr. Davis. I was just going to comment that one of our provider relations representatives said the exact same thing in our internal chat. So we agree with that position too.
Anyway, we'll get together and we'll try to hash it through and see if we can come up with something that makes some sense otherwise.
Appreciate y'all for entertaining that discussion for us.
Sure.
Coming down to the last, some questions on the EPSDT. I know we've gone over this several times, but I think there still can be some confusion and issues with getting things taken care of through that program. So if each MCO could kind of go over those last two bullet points for us, that would be great.
Sure. I'll start. This is again Nicole with Avisis. For the EPSDT authorization process, it actually follows our same process for prior authorizations. We don't have a special form to request an EPSDT service. So the same place that you access the Avisis authorization form on our portal, you'll use that same form to submit an EPSDT request. If a practice utilizes DMS's universal authorization form, Avisis is configured to accept that form. So if you'd like to use that, you're welcome to send that in and we can process it. Just a FYI, there are some data elements that are not on the universal form. So it may require an outreach to the office, which may postpone our normal 2 business day turnaround time. But again, it's the same information that is on the portal. And if you like me to, we can show you in our portal manual exactly where that information is. But I think most are familiar with and comfortable with using our portal.
Nicole, quick question.
Yes.
I know way back when we first started talking about EPSDT stuff, I think we had been advised to write on that form EPSDT to set it apart from regular prior authorization. Is that still the case?
Yes, it is helpful if you can please write EPSDT on the form to help, like you said, make it stand out. But it isn't required, but it is helpful if you can write EPSDT on the form. Miranda or Leanne, is there anything else you'd like to add?
But nothing additional. Thanks, Nicole.
Okay, thank you.
John Davis, if I can go next with iQuest and Anthem, I I want to mirror Nicole's words again. So she's so eloquently spoken. I appreciate it. She's explains it better than me. Ultimately, as far as we're concerned, the 20 and younger, anything that the child is determined to need with a medical necessity would be theoretically covered. So, and we don't have any special forms either. We use we have our portal PA process, and we do utilize the common form that the DMS distributes. So again, similar. We don't really you don't have to mention EPSDT necessarily. We kind of make that assumption. If you're asking for something that's let's say that's identified as not covered without some kind of other justification, clinical justification.
When you say common form, what is that?
That's the universal Medicaid prior auth form.
No, the one like on your portal. And the point, like I'm the one that asked for this to be put on specifically because literally every time we ask, it's on the portal. So that's why if you read this discussion, it says with instructions and or screenshots. So what would be amazing for those people that don't spend a lot of time on the portal or are newer employees, if you could literally do screenshots and say, here's your opening page, here's an arrow, click here, it will take you to this page, and this is where the form is. Because I have gone on the portal when your guys are like, oh, it's on the portal, go look for it. And it's like down a little rabbit hole, and I never find what it's supposed to be so easy to find. Now that could easily be operator error on my part. But if I'm not able to find it, then I wonder what the offices across Kentucky are running into when they have an employee that's trying to locate these things. So and I appreciate Nicole explaining, but is that something that would be possible that someone within your organizations can do some screenshots and have that emailed in so we can see exactly where we're going to be able to get the correct form filled out?
So Dr. Munson, for visas, that's exactly how we have it outlined in the provider portal manual. So the manual does have screenshots and it does have the arrows pointing you to exactly where it is. So we can make sure that your team receives a copy of the manual. And then what I can do is take the 2 pages that outlines where the information is and then how to look at the information. I can share that with Aaron and with Sarah at the KOA so we can route that information out to the committee members.
Okay, perfect.
And this is Tanya from March Vision. We don't require a form. It's just the standard process of getting the confirmation. And if it's medically necessary, it's assumed covered. And that is on the screen. I did provide where to find the benefits for each plan. And Sarah will share that document.
So your standard process of getting covered, so like a patient who's a +8 and they've broken their 3rd pair of glasses. So they would just go through the standard process of asking for pair number 4 with March.
So under the benefits for that particular member, it's going to say what the replacement requirements are. And then you would just follow the process of getting the confirmation for that and filing it. So if it's a covered benefit, then it's going to be paid with the appropriate confirmation service. And you can chime in if I'm incorrectly speaking there.
No, you've got it correct. And so Dr. Munson, to answer your question, yes, you would just need to have your office or any of the optometrists either use our portal, use the IVR, or speak to a customer service representative. Just confirm, that member, has lost. I think you said, your example was their 3rd pair of glasses. We'll issue you a confirmation number, and then those services can be rendered. So there's no, as Tanya was mentioning, no difference in process.
So there's not a separate form like with the other 2 entities. Correct. Where we have to submit. Okay.
Correct.
All right, thank you.
You're welcome.
Now, this is Christy Medina again from iQuest. I did want to let you know that we actually put together screenshots, not just for this item, for some of the other bullets throughout the agenda that we actually were going to send after the call, after the discussion. So kind of like with those arrows, kind of as a guide. And we'll have that on our portal too, just as a, quick reference for everybody.
Excellent. Thank you.
Dr.
This is
Munson,
Kimberly from Passport, and we did that as well.
If you guys don't mind to send that to me, this is Erin. I can turn around and get that out to the TAC as a whole.
Perfect. Thank you, Erin.
and Dr. Munson, just as a friendly reminder, the children in the foster care children, prior authorizations are not required for their replacement glasses or for follow-up visits because they're in the foster care program. So just a friendly reminder.
So that is only for their replacement pair, not if they are on pair 3+. Or is that every pair if they break them every 2 weeks and there's no PA?
Danny, can you help clarify? It's my understanding that that's every pair, but tell me if I'm right or wrong.
No, you're correct. So the replacement eyeglasses and the additional exams is covered on actually unlimited frequency with no prior auth, as long as they're in the foster group.
Okay, that's excellent. Thank you, guys.
Yeah, but if you do want to do like the unbreakable frames, the upgrades, those that will require the prior auth, but just the standard replacement glasses, it doesn't require.
Okay, excellent. Thank you.
Good. Dr. Davis, I've got a question for you from what you had mentioned on iQuest stuff. You said that if it's considered medically necessary and not covered under the standard benefit, then it would go to the EPSDT stuff.
I probably didn't state it correctly. We make an assumption that everything that you request for one of your child patients, right, 20 and younger, if we assume it's always, if you ask for permission to provide a service that may not be a standard covered service, we assume it's EPSDT based. Did I say that poorly again? So we don't really, you don't even need the terminology really, I guess is kind of what I'm suggesting there. Go ahead.
It just jumped into my mind when you said that. Would that include medically necessary contacts?
Oh yeah. Yeah, especially and even subsequent eye exams, right? The patient comes in, they go to now 3 months, 4 months, 5 months later, they go to a school screening, they fail the screening, right? Or they go to the pediatrician who sends a patient back to you, say, look, the kid was 20/30 minus in their other eye, whatever, whatever you get, we all get them all the time, right? All you guys. So then that would be, even though theoretically the quote Medicaid program doesn't cover that second, we'll call it a routine eye exam for lack of a better term, that exam under EPSDT, it would certainly be covered because you would have to you'd want to know why that vision is reduced. So you have to do basically a medical visit, really, is what it would become. And you can define it any way you want. But that's how we would look at that one as an example. So that's really an unlimited benefit, even though the state suggests that they would get one eye exam every year, which we know better. And that could even go to things that, like, certain states, believe it or not, do not cover vision therapy for Medicaid. They don't cover it. But under EPSDT, is that service now covered by that state? Of course it is, right? Because again, if you can justify a medical need for that, then theoretically it supersedes the state's limitations. Hope that made it a little clearer.
Yeah, I think so. Well,
This is Sarah.
Short of anybody else.
Can you hear me, Matt?
Hello?
Can you hear me?
Barely.
Okay, sorry. Just one thing going, Nicole, while we have on this call, I've received 2 phone calls since we've been on this call about doctor's offices being terminated with, I guess, the May 1st issue. And
and they're saying that they did not receive anything. Can you go over again what the offices would have received before they were knocked off? Because I know we've emailed back and forth on this and everything, and I have big plans in the future for the Board of Examiners to send this file to the DMS, so this does not.
That would be great. Yeah, that would be great.
I know that's not up to me at this point, but I guess I just need
Yes.
to know, and I will forward you over these 2 offices as soon as we get off. But
Perfect.
I just feel
Yes.
like it's an issue. So if you don't mind, when I receive calls, if you don't mind to tell me what they should have received in the first place, if that's okay.
Okay, sure. So if you can think of 2 buckets, okay? You're going to have your bucket for terminations that are due to the Kentucky Medicaid ID not being active. If the Kentucky Medicaid ID number is not active, then we have to term the provider until they reactivate their Kentucky Medicaid ID number. If that happens and there isn't a lapse between the termination date and effective date with the Kentucky Medicaid ID number, we can reinstate them so that there isn't a lapse in their Avisa's credentialing status. But please note that if it takes, the 2 to 3 weeks to get the DMS system to reflect the new license information, then unfortunately that's how long they're going to stay inactive in Avisa's system. And then it's my understanding that DMS does send out notices to providers that tells them that they have to recertify their Medicaid ID number once every 5 years. And I'll defer to DMS to confirm that there's also an annual update that the provider should be doing also. So as long as the providers are doing those 2 things, there should not be a lapse in their Kentucky Medicaid ID number. But as you stated, Sarah, when the board updates everyone's licenses, if that information is not getting over to DMS, then unfortunately they have to do what they have to do. And in turn, we have to do what we have to do. Does that help with the first bucket?
Yes.
Okay, so the second bucket that a provider could be termed from Avisa's is due to their inability to complete re-credentialing timely. If the re-credentialing is not completed timely, then again, we do have to term the provider. We do have a standard process to notify the providers of their re-credentialed requirements at the 6-month period, 4-month, 3-month, 30 days, calls from the PR reps, as well as note everyone who is scheduled to be re-credentialed within 6 months. They do get a monthly notice to participate in our credentialing webinar. So again, if you can please share with us who those providers are, we can figure out which bucket they fall into, and then help them through the process.
Well, I appreciate it. So thank you. And hopefully by next year, we'll be not having to deal with it. So.
That would be great. That would be great. And again, if there's anything we can do, please let us know. I know when we got the first list, I sent it over to you and said, "Uh-oh, it's going to happen again." So we try to keep you informed too. But we'll work on it. We'll get better.
Okay, sounds good. Thank you. Sorry for the interruption. Okay.
Oh,
Matt,
fine,
this is James.
Yes, James.
Back at the top of our agenda, about to finish up the meeting here, but at the very top, there was something about it's with March on dual eligibles. Let's see, down just a little bit from there. I can't see it exactly on the agenda, but anyway, yeah, let's see.
Oh, bulletin on.
Yes, DSP plans billing to passports. We got a notice, just a newsletter, I guess it was, from March, and I didn't fully understand what that was talking about. It just says in Kentucky, some benefit plans administered by March Vision Care cover both routine and necessary medical services, but our new Passport Health, Medicare, HMO, and DSNP benefit plans only cover routine vision services. And it's saying that all claims for routine services performed by an optometrist and ophthalmologist for Passport Health, Medicare, HMO, and DSNP should be submitted to March Vision Care for reimbursement. Then the other bullet point that I didn't understand entirely was it says all claims for medical eye services, treatment for conjunctivitis, glaucoma, etc., performed by an ophthalmologist, MD or DO, or an optometrist, and are within the scope of licensure for Passport Health, Medicare, HMO, and DSNP plans should be billed to the medical plan. These claims should not be directed to March Vision Care, or it will result in a delay of payment. So if somebody could explain that a little better for me, I would appreciate it.
Sure. This is Tanya from March Vision Care. So for Passport, March Vision Care is only responsible for routine vision services. So the only claims that we are going to reimburse are for routine services. And then anything outside of routine services that are covered within the OD or MD scope of licensure would need to be billed to the health plan, which is a little different from our other plans, right? So March Vision would pay claims for medical if it's within the scope of the license. But for Passport, it's a little bit different. We're only administering routine vision services.
And to add a fine, sorry,
Go
I was
ahead.
just going to say, to add a fine point to that, that's what Tanya just stepped through is specific to those Passport, Medicare, or dual special needs members. So that's specific to that kind of smaller, subset of members that have that, like I said, Medicare or dual special needs plan membership.
So we definitely have to be credentialed with Passport in order to participate in that level of care.
That's my understanding, yes.
Okay. All righty, I appreciate that.
You're welcome.
Any other comments? Everybody good? Well, our next meeting looks like August 4th. If that date still stands good, then we'll entertain a motion to dismiss or adjourn.
Can I ask for
Oh, wait a
one?
minute. Oh,
I apologize.
Nicole.
If I may really quickly, we did want to introduce Dr. Worth. He is our Vice President of Vision Services. He will be representing along with me for the Avisa's team on clinical issues. So I just wanted to make sure that everyone knew Dr. Worth. And Dr. Worth, if you'd like to say hello to everyone, please.
Yes, hi. Thank you all for including me today. I'm just kind of been listening in as this is my first call, so I wanted to just listen and learn from the rest of you. So I want to thank you very much for inviting me here, and anything that I can do to help support the team, please feel free to reach out to me personally. And I look forward to speaking with each and every one of you in the coming months. That's all. Thank you.
Thank you. Now I'll entertain a motion.
Make the motion to adjourn.
Well, second.
All in favor?
All right.
Thank you all.
All right, thank you so much.
Everyone.
Thank
Have a
you.
good
Afternoon. Thanks,
you.
everybody.
Good
Bye-bye.
Thank
Thank
you.
you all.
Dr. Upchurch, before you leave, this is Miranda. I just wanted to say hi to you and Daniel. I saw him in the kitchen earlier.